What do you think would have happened without your parents seeking help outside the NHS?
To be honest, I don't quite know what I would have done without my mum, especially because she just went to the ends of the earth researching everything for me, like abroad and everything. So obviously the NHS felt it was quite, I couldn't have got more support, but they were quite in quite a sticky situation because obviously the blood test came back negative. So it was quite tricky because of that. So we went abroad and everything, and then there was a lot of different opinions, so it was all just a bit confusing.
There's a question there about how could the D&E organization improve information for particularly the participants?
Before going on D&E, we were told check yourself and wear repellent, but we weren't really told anything about the disease itself. Like we were never told what symptoms to look out for, what the actual disease will entail. So it would be great if they.
How do you think that you can influence this? How can we get better awareness and understanding, both for young people and families?
Well, I hope that someday it will become a norm for like children when they go out and play at lunchtimes, for it to be a norm to check up for ticks, and like when they come in from the garden, for just the parents to automatically just check all over the body. Because I had no idea how small they could be, and no one really stressed that enough to me, so I didn't check as hard as I should have. So hopefully that message gets out.
Yeah, I think that we need all the help we can from wise young people like yourself to think how you actually do use social media and other strategies to really inform, because there's still wide open gaps in knowledge.
Yeah,
Arlene, over to you. I'll let you chair probably.
No, not at all. I think we've got questions coming in that both look at the experience but also the prescribing side as well. And Millie, I can relate to what you're saying because my son was also bitten on a Duke of Edinburgh and he knew about tick removal, but he didn't know about what to look for afterwards. And so you've hit a key area that we really must all focus on. One person has asked you actually, Millie, I could just find that question. When did the symptoms first come on in your case? When did you first realise you were becoming ill?
It was 2 weeks after the bite, so 1 week after finding the tick. So yeah. That's
helpful to know. And we have one or two questions directed towards yourself, Gareth. One is, why is it that ticks can be tested for Borrelia by PCR, but humans cannot? You touched on that in your talk.
Oh, okay. I mean, I think that's simply that if you've got a tick that's carrying Borrelia, you've got a very, very tiny volume in which that tick is distributed, and it wouldn't be difficult to crush the tick and extract DNA and to amplify Borrelia. Whereas, you know, you can't really go around crushing teenagers and amplifying all of the material. You know, if you think about it, what material can you take that might be infected? And it's clear that this is very unlike the bloodborne viruses. You know, you're not going to find spirochetes in the blood for the most part, and so you're certainly not going to be amplifying any genetic material from spirochetes from a blood sample. I mean, we do know that if you do biopsies of synovium, you know, the lining of joints that can be infected, or the erythema migrans rash as well, that you can actually identify infection and amplify that. But you know, these are very invasive kind of tests that you wouldn't be doing naturally, and I think it's mainly a reflection of the distribution and the lack of access to the appropriate diagnostic material that means PCR is really not a very effective tool in this particular human infection. Yeah, go ahead, Alina, I'll let you lead the way.
So there's one related to treatment here, which says they were interested to hear that Millie improved on rifampicin. Do you think this is likely to have helped the Lyme disease or perhaps another infection? Any thoughts, Gareth?
Yeah, I've thought all along that it's quite probable that Millie had a pathogen that we weren't even able to test for, and that and curiously that it hadn't responded to high dose amoxicillin. Well, in fact, you did get both amoxicillin and azithro, and then various combinations of limacycline and clarithromycin and all sorts of different things that have been tried, and then the rifampicin was added, and it was really striking, just remembering how much difference that made. Obviously rifampicin treats atypical mycobacteria and well, it treats TB as well, but I didn't think for 1 minute that Millie had got TB. I think there's a lot to learn, and that we would be incredibly arrogant to ignore Millie's experience. But I don't have a clear answer.
Yeah. Thank you. And related to that, there's a lovely comment saying, very happy to see Millie's made so much progress, but however, many people in her position can only access the 3 to 6 weeks of antibiotics as per the NICE guideline. How can they be helped?
Yeah, well, my answer is that I think for any infectious disease and secondary and tertiary practitioners, this is beyond primary care. This, I think, does need some specialist help, and we do really need people to pick up the baton and start thinking about this and start recognizing that we don't have all the answers. There are little moments when I think that what we're conducting is yet another rerun of the Tuskegee disaster, where people were allowed to live with syphilis so you could document the natural history without giving antibiotics, even when we knew penicillin was available and treated the disease. Unfortunately, penicillin isn't that effective against Borrelia and some of the other co-infections, and so we just need better diagnostics to really understand whether this is actually a continuing infection that does require longer-term antibiotics, and in which case it needs to become mainstream NHS approach. And I would really encourage people to listen to their patients, that if you've gone down the guidelines and the young person or the child is still not well, don't just write them off as a malingerer. I mean, if anything comes out of tonight, listening to Millie, you were not malingering. You really wanted to be well, and you weren't. You were not well. And it's great that you've got through it all. So that would be my plea. And there's a question there about, should we treat Bell's palsy with antibiotics? And it's a good question. I mean, I clearly would be encouraging everybody to be thinking about Lyme disease as part of the differential diagnosis. I would really want people to be taking a very good history and a very thoughtful approach to exposure. I mean, if somebody has, if there's really a very, very unlikely risk of tick exposure, then I would be looking for other explanations for the Bell's palsy. And of course, actually Jack touched on this in the seminar, in the webinar last week as well. Think about the differential diagnosis and think about the context. Obviously send the tests. If there's anything else to go along to support the diagnosis of Lyme disease, if there's an unusual rash of any sort, for heaven's sake, get on and treat it without delay. But if there's nothing else, then clearly there are other causes of Bell's palsy that need to be thought about as well. So I wouldn't rush into treating every child with Bell's palsy with high dose amoxicillin.
History, isn't it? Travel history.
Yes, it's about listening to your patients, actually, more than anything else.
Thank you for that, Gareth. Here's an interesting one. Have you seen any cases of autoimmune encephalitis related to Borrelia?
It's a good question. The short answer is no, and we're really ready to investigate and to think about. These are kind of post-infectious results. I mean, we see absolutely appalling autoimmune encephalitis following herpes simplex infection and so on, and it's a growing, expanding area of neuroscience. But in my own clinical practice, no, I did not. We didn't see any evidence of that. it wasn't, well, I mean, to be absolutely honest, you really do need to have a pretty thoughtful threshold. And again, I think this is where working with a group of colleagues is so helpful, to be able to decide, actually, this young person does merit bringing into hospital for really thorough investigation, including lumbar puncture and thinking about that kind of differential diagnosis.
Thank you. Thank you. And I think you've covered this one along the way, but the questioner has asked, how would you say, and I presume it means Millie had more and more antibiotics prescribed, what were the reasons given by the doctors? I think you've covered that.
I think that's one for you, Millie.
I think it was just because I was still so unwell, and there was not really much else I could do. Don't honestly know, to be honest.
It's a provocative question, because would you have got better without those antibiotics? It's a question that I ask myself, not just about you, but about a number of other young people that I've looked after, and in the absence of a proper randomized controlled trial with where there is a really, really clear presentation, as you had, I think it's difficult. There will be people who look at the available data and rest assured that this is not a continuing infection, and therefore we shouldn't be treating it with antibiotics, and that if you do use all of the adjunctive support and potentially some of the other supplementary therapies that many people on this call know far more about than I do, that you can also get good results. And so I think we need to keep an open mind.
Thank you. And a question here, was Millie ever tested for Q fever?
For Q fever, yes, she was, and was negative.
That's helpful for our inquirer there.
Yeah.
So we're coming towards the end of the questions now, and I think a final one I'd like to ask Millie is, going through your experience, Millie, what words of encouragement or advice or thoughts would you like to share with health professionals, who are mainly the ones on the webinar tonight? The doctors that you saw and the healthcare staff that were looking after you. Is there anything you'd like to add about your experience and how they can better understand how they approach a young person who's so ill and doesn't know what's wrong?
Firstly, thank you for looking into it all. And then I guess just reassurance, because it was so scary having a lot of different doctors saying a lot of different things. Thankfully, I had Gareth, who really, really eased my anxiety, because it was a very scary period of my life. But just reassurance and testing, because it was obviously, because the blood test came back negative, it was also kind of like, oh god, what's really going on here? So yeah.
Yeah, I mean, it's worth saying, Millie, that the BCA lab did come up with some positive results, and I think that we still need to keep evaluating the role of ELISpot and other diagnostic tools, ways of measuring specific immune responses. I mean, the existing data is not that convincing around the ELISpot, and part of the problem is that the BCA and other colleagues have not published their data in any peer-reviewed journals, and so we are left with uncertainties. But it wasn't that there was that some people hadn't found some evidence of infection in your case.
And so a final question for Gareth, and then we'll close the webinar for tonight. Do you have any key messages you would like to leave with our primary care colleagues and or our secondary care colleagues with us tonight, Gareth, in terms of what you've seen over recent years with tick-borne infection and Lyme disease, particularly where children are unwell and causes can't be found? Any final thoughts?
Well, I think I've said it all the way through that there does need to be some professional awareness. There does need to be better professional education. Millie was not well served by a colleague in primary care who just took a pair of gloves off the wall and squeezed that tick and squeezed all the contents of that tick's stomach through the mouth parts into Millie's subcutaneous tissues. It is about growing knowledge and thinking and listening to our patients and believing them when they come up with some really bizarre symptoms that we don't necessarily understand how that's happening. I've still got no idea what was driving the muscular twitching that you were having, Millie. You know, what's the actual pathogenic mechanism for that? I am at a loss to understand, but it was very real. And just because I don't understand it doesn't mean it wasn't happening. And that's where the joy lies in really trying to be to be listening rather than preaching, and make sure that we do everything we can to make balanced decisions that are to the child's best interests.